Assalamu alaikum students. In this lecture we will discuss about tuberculosis. The learning objectives are introduction to tuberculosis. What are the risk factors? Spread of the disease and classical symptoms, extrapulmonary tuberculosis, investigation, management, and prevention. So start the lecture. Pulmonary tuberculosis, an infectious disease caused by a bacterium known as Mycobacterium tuberculosis. Okay, when this bacteria reach our lung, they cause infection in the lung. They can also infect other organs, generally lungs. Latent TB is a type of tuberculosis in which there is no symptoms. Okay, there is no symptom in latent tuberculosis, but 10% of latent tuberculosis can progress to acute TB. Okay, acute tuberculosis. The classical symptoms of pulmonary tuberculosis are chronic cough. A patient present with chronic cough with low grade fever. Okay, and this fever is also chronic, more than 3 weeks. Patient comes to you with fever more than 3 weeks and cough which is also chronic. Then other symptoms: fatigue, loss of appetite, night sweats, sometimes there is massive moptisis. This is due to erosion of pulmonary vessels. This causes aneurysm formation and massive bleeding. This formation of aneurysm is known as Rasmussen aneurysm. Okay, there is massive bleeding as a result of erosion of the vessels. Now we will discuss about extrapulmonary symptoms. The extrapulmonary symptoms are due to involvement of organs other than lungs. These include pleura, which cause tuberculosis pleuraceae. Okay, when it involves CNS, it is tuberculosis meningitis. Similarly, when lymphatics are involved, it is scrofula. Mainly cervical lymph nodes are involved and it is known as scrofula. Similarly, urogenital tuberculosis due to urogenital system involvement. Similarly, bones and joints are also involved. The involvement of spine, known as Pott's disease. Okay, these are the extrapulmonary involvement of tuberculosis. There is a condition where a potentially widespread form of TB. Okay, widespread form, which is also called disseminated TB and or miliary TB. approximately 10% of TB can progress to biliary TB. Okay, risk factors of tuberculosis. First one is overcrowding, malnutrition. All these can cause tuberculosis in patient, as there is low immunity, decrease in immunity cause increase in chance of TB. Okay, similarly silicosis can cause 30 times increase in risk of tuberculosis. Similarly smoking cause 2 times increase in risk. Alcohol and diabetic patient have 3 times increase in risk to get TB. Okay, these are the main risk factors of TB. Other is HIV infected patients also have increased risk of TB. Okay, as there is decrease in immunity, more chance to get infected. So these are the risk factors of pulmonary tuberculosis. How TB spread? TB is spread through prolonged close contact. Okay, prolonged close contact can cause wide spread of tuberculosis. Similarly through droplet infection. Okay, these are the factors which cause tuberculosis to spread. Now we will discuss about investigations. Okay, for specimen. Okay, then radiological investigation and some diagnostic tests. So the main specimens which are used are sputum, tissue biopsy, bronchial lavage, gastric lavage for GIT tuberculosis. Okay, in which the bacterium is ingested. Gastric lavage. Similarly radiological investigations are X-ray and CT scan. The diagnostic tests are skin test, in which second one is sputum staining and culture. For staining, 2 types of stains are used. First one is Nelson staining. Second one is fluorescein staining. Okay, the medium are LJ medium, Levenshtein-Jansen medium. Okay, NET test. In NET test we will do PCR of tuberculosis nucleic acid or DNA. Okay, this is also known as gene expert. Okay, similarly we can also drop fluid intramuscular fluid, okay, for diagnosis. These are the main investigations. The gold standard is gene expert, okay, gene expert, okay. Other main investigations are culture and skin test. In X-ray we can see the consolidation of upper lobe of lung. Similarly we can do CT scan, okay. These are the main investigations of TB. Let us discuss about management of tuberculosis. We will divide the management into medical and surgical management. So for medical we will further divide into two main headings. First one is standard treatment, and second one is glucocorticoid treatment. The standard treatment consists of three main lines: first line, second line, and third line treatment. First line treatment involves main drugs which we can be remembered by a mnemonic, which is RIPES, RIPES. R means rifampicin, isoniazid, pyrazinamide, ethambutol, and streptomycin. Okay, these are standard regimen, and it is usually given for 6 months, 4 drugs for 2 months, and 2 drugs for 4 months. Okay, 4 drugs are RIPE, RIPE, and 2 drugs are isoniazid, RNI means rifampicin and isoniazid. These are standard regimen, and it is given for 6 months. The second line drugs which we will give if there is resistance for first line, these are amikacin, kanamycin, and capreomycin. Okay, these are second line drugs. And third line drugs are linezolid, clarithromycin, amoxicillin, and imipenem, meropenem. These are third line drugs. Okay, now we will discuss about MDR and XDR and resistant tuberculosis bacteria. MDR drugs are when bacteria resistance to isoniazid, rifampicin, okay, and second line drugs. Okay, XDR TB are those bacteria which resistance against isoniazid resistance plus quinolones and any second line injectables. Okay, these are XDR. Okay, now when we will give glucocorticoids is given when there is pericardial disease, okay, pericardial involvement, meningeal involvement. Similarly, endobronchial disease. In this condition we will give glucocorticoid. Surgical management is given when there is massive hemoptysis and loculated empyema and spinal cord compression. When spinal cord is compressed, for example in Pott's disease, we will do surgery. Okay, spinal cord compression. Okay.